Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. Subscribe at kevinmd.com/podcast. Today, we have a special sponsored episode from Stryker Oral Care. We welcome Dr. Barbara Quinn, a board certified adult clinical nursing specialist and fellow of the National Association for Clinical Nurse Specialists since 2020. She has 30 years of nursing experience and specializes in evidence-based practice to improve patient outcomes. We also welcome Elias Curry, the Market Director of Quality and Risk at two medical centers in Arizona. Today, we'll be discussing patient safety in focus, helping to address risk factors associated with non-ventilator hospital-acquired pneumonia. Find out more at kevinmd.com/Stryker. That's Stryker with a Y, kevinmd.com/STRYKER. The link will be in the show notes. Barbara and Elias, welcome to the show.
Thank you very much.
Now, hospital-acquired pneumonia is the most common hospital-acquired infection. However, most of the attention has been on ventilator-associated pneumonia, even though 65% of hospital-acquired pneumonia cases occur in non-ventilated patients. Barbara, can you explain what ventilator-associated pneumonia is, and when did you first learn about non-ventilator hospital-acquired pneumonia?
Well, that's a good question. Ventilator-associated pneumonia, most people are quite familiar with. That's a diagnosed pneumonia that occurs 48 hours after mechanical ventilation in the hospital usually. And on the other hand, non-ventilator hospital-acquired pneumonia is a diagnosed hospital onset pneumonia in non-intubated patients, which is really the majority of the patients we see in the hospital, right? So my first awareness of non-ventilator hospital-acquired pneumonia, or NVHAP as we like to call it, as a patient safety issue was back in 2010, which is a long time ago now, right? I was rounding on patients in one of our ICUs, and one of the RNs in the ICU, who was also on the rapid response team, asked how many non-intubated patients we were getting that had pneumonia in the hospital. And as a new team member in our quality department, I wasn't sure. So I asked around and found out that because we weren't measuring it, nobody really knew. It was really quite an unknown, and nobody really knew how to answer me. So I went to the literature, and nothing there either besides ventilator-associated pneumonia. And so that's what launched me into this program of research, really looking at this hidden pneumonia that was occurring in our hospital. The very first 1 year retrospective review, we found 115 cases of NVHAP in our hospital with very few VAPs. And so that showed us that it was really occurring much more often, but it had just hidden under the radar because we weren't required to look at it.
So, Barbara, what kind of factors have contributed to this lack of awareness or emphasis on non-ventilator hospital-acquired pneumonia compared to ventilator-associated pneumonia?
Well, I think, again, we focus in our hospital systems, for better or for worse, on quality and safety metrics that are required to be reported. And unfortunately, to this date, NVHAP is still not a required reportable metric.
Elias, tell us what misconceptions about non-ventilator hospital-acquired pneumonia do you encounter among healthcare professionals or leadership?
Good question. I really think the biggest misconception, particularly with NVHAP, is that it doesn't carry as much weight or impact as some of the other hospital-acquired infections. Like Barb said, it's not measured, right? And that's kind of apparent on all levels. For nursing, we're so proactive on awareness of falls and the mitigation strategies and sepsis and our device utilization, and we proactively work on strategies to stop those from occurring. Quality and infection control focuses on compliance with prevention. So they do audits on our fall strategies. We do C. diff testing protocols. We have device days that we look at periodically, morning briefs, afternoon briefs, to see when we can remove those. But we don't typically do so much around pneumonia. So we don't always look at the oral care compliance or how often that's happening. We might put the incentive spirometers in the rooms, but don't really look to see how often they're being used. And you might overlook something like the head of the bed being at 30 degrees. And so there's just not enough really focus. And I think that's because NVHAP just isn't as recognized. And so when you start bringing up issues with it and are trying to develop strategies to reduce it, you face some resistance on the importance of what you're doing and why that item might take priority over some of the other things that are already being measured and looked at from different agencies.
Barbara, are there specific patient populations who are more vulnerable to developing non-ventilator hospital-acquired pneumonia?
There's definitely some patient populations who are at higher risk. But when I'm asked this question, I like to go back to why is anybody at risk for pneumonia? There's really three mechanisms, Kevin, and it just takes one risk in each of those categories for patients in the hospital to be susceptible to pneumonia. So the first one is oral pathogens. Most people don't understand that the majority of hospital pathogens originate in the mouth. And it only takes 1 to 2 days in the hospital to disrupt our normal microbiome and make us susceptible to those pathogens in the mouth. And then secondly, those pathogens then are aspirated or microaspirated, little bits of saliva slip into the lungs. And that happens with even healthy people. We normally microaspirate a little bit each day. So you put together those oral pathogens from the hospital that are aspirated in our patients are at higher risk for aspiration. And then those patients also don't have the same strong host defenses that normally would fight off an infection like that. So there are some patients who fall into all three of those categories and are at higher risk than others. For example, cancer patients, elderly patients, patients with common comorbidities like heart failure and COPD. But what we found in our research is that all people are at some risk. And that's why we look at pneumonia prevention in the hospital as a standard of care for all patients, because all patients are at some risk.
Now, each of you have different clinical perspectives, so I'm going to ask the same question to both of you. Elias, can you walk us through what it looks like when a patient in the hospital develops non-ventilator hospital-acquired pneumonia and how their stay is impacted by it?
Yeah, and so in my role with quality and risk, we look at a lot of the risk associated with that from my perspective. So you have a patient that's developing pneumonia and their risk is right then increasing for other issues that they could have happen. So you increase their length of stay. And some studies are suggesting that could be up to an increase of 15 days. And a higher length of stay increase is also associated with higher risk for other hospital-acquired conditions and HACs. You know, you're putting them at a higher risk for pressure injuries because they're in the bed longer, they're sitting there longer, they're in the hospital longer. There's a higher potential for fall and fallout in that, so they could get injured with a fall injury. They're going to be put on more antibiotics. And so then you look at C. diff coming into place, right? So you're having an increase on antibiotics, you increase those antibiotic resistant organisms that you're putting them at risk for. And then also there's a lot of association between sepsis and mortality. NVHAP is one of the most frequent causes of hospital-acquired sepsis. And so we need, I think, look at that. And then also it's associated with a higher mortality risk. So a patient that develops hospital-acquired pneumonia or NVHAP is really being placed in a high-risk, vulnerable situation.
All right, Barbara, same question. Walk us through what it looks like when a patient in a hospital develops NVHAP, non-ventilator hospital-acquired pneumonia, and how their stay is impacted by it.
You know, all the things that Elias spoke of, 100% validated in the literature. There's a study, specifically a large study of Medicare patients, that they found when they acquired non-ventilator hospital-acquired pneumonia, 36% of them went on to develop sepsis. And like Elias said, those sepsis patients, especially hospital onset sepsis, those patients have much worse outcomes, much higher mortality and other complications. So that all those things that he said, absolutely true. I think one thing that hasn't been mentioned yet is what happens to patients if they survive their hospitalization and then are discharged. 40% or more are discharged to a higher level of care than they came to us with. And so that's a cost and a price and an impact that we haven't even started to look into, but that takes a real toll on our patients. Think of their families, changing all the ways that they deal with functional decline after a severe hospitalization. So all of those things take a big toll on our patients and their families.
You're listening to a special sponsored episode of the podcast by Kevin MD, Patient Safety in Focus, helping to address risk factors associated with non-ventilator hospital-acquired pneumonia. Find out more at kevinmd.com/Stryker. That's Stryker with a Y. kevinmd.com/STRYKER. The link will be in the show notes. Barbara, what are some ways hospitals can implement prevention strategies to address the risk factors of non-ventilator hospital-acquired pneumonia?
Well, I think like any prevention program, a hospital needs to apply implementation science and that change management strategy to achieve and sustain a change in practice. So this includes education, very important leadership support, visible leadership support, and then that ongoing feedback and engagement of the bedside staff. The examples of strategies for this particular topic that address all three of those mechanisms that we talked about that lead to pneumonia. We want to reduce oral pathogens with that oral hygiene and oral care.
Mm-hmm.
We want to reduce the aspiration risk by elevating the head of the bed or performing bedside swallow screens. And one way to strengthen the normal physiologic response is to do things like get the patients up and out of bed.
So again, I'm interested in hearing both your clinical perspectives. So Elias, let me ask this to you, and I'll ask the same question to you, Barbara. Elias, in what ways do healthcare professionals like nurses, nursing assistants, and other clinical staff support the prevention of NVHAP outside of infection control programs?
I think it starts with the frontline staff, right? In quality and infection control, we can put together all the processes and programs, but if you don't have the nurses and the front line bought in and understanding the purpose and the problem and what we're trying to do with the solution, then you're really not going to get anywhere. You can make plans all day, but it's really truly the people that are enacting those plans that are going to see it successful. And so I think that you create champions in your nursing flow. I think you create people that are really bought in. And once nurses and once those clinical teams start understanding what's going on and you've done a good job of painting that picture for them and they're bought into it, then that's where you're going to truly see better outcomes and an increased awareness in something like NVHAP and a reduction actually in what you're trying to achieve there.
And Barbara, same question. Tell us, in your perspective, how can healthcare professionals support the prevention of NVHAP outside of infection control programs?
Well, really, most prevention strategies for pneumonia don't require a provider order. So it really comes back to, like Elias says, back to the bedside staff and really that nursing standard of care. So nurses, based on evidence, can update their policies and their standards then to align with pneumonia prevention activities. And I want to call out the nursing assistants, the CNAs who provide a lot of the basic care. They take care of ambulation, oral hygiene, and those types of things. They have to be included in the education and included in the ongoing process improvement. Some of our CNAs were the strongest champions for oral care. They became a very passionate part of the healthcare team.
Barbara, you implemented some of these prevention strategies at your hospitals, and your research and reduction in non-ventilator hospital-acquired pneumonia was published in the Journal of Nursing Scholarship and the American Journal of Infection Control. Can you briefly walk us through the oral care protocol that you implemented and the impact it had?
Yeah, I'd love to. I think we started because the majority of NVHAP that we found in our hospital occurred in adult patients. We really started our focus there with that population. We began on one unit And then we quickly spread to all the adult units in the hospital. We developed a standard oral care protocol that was based on literature and then was eventually approved by the board of the American Dental Association in 2017. We made sure we included all patients from self-care to dependent and ventilated patients, of course. And we had to purchase new oral care supplies because what we had was of such poor quality, it was really embarrassing. We had toothbrushes that the bristles fell out of. We had blue water to oral rinse with. Don't know if Elias had the same experience, but things that weren't even therapeutic, we were offering to our patients to take care of the oral care. So getting some good products were important. And I'll mention here, we did choose the Sage Stryker oral care products. We laid out all of the different products that were available to our hospital, and they were voted in by the staff and leadership because they met the evidence-based requirements from the American Dental Association. So we did use that. We also had to do quite a bit of education. It's surprising how many people, including nurses, nursing assistants, and patients and family members, that really have no idea that the germs that cause pneumonia start in the mouth and how important it is to keep that mouth clean. So we did see, putting that into place, we had a dramatic increase in oral care frequency and then a decrease in hospital-acquired pneumonia. That first year, we estimated we saved 8 lives, prevented 500 extra hospital days and $1.72 million, and that's after subtracting the cost of the oral care equipment. So we felt like that was great. And as we continued that to measure for 4 years, we found that we actually increased prevention and continued to see the same results sustained.
Now, Elias, similarly, you implemented an oral care protocol at your hospital, including Stryker's Sage Self Oral Care product, and presented a poster on it at the Society for Healthcare Epidemiology of America conference. What was your approach to implementing a new protocol?
Yeah, so we really wanted to understand the problem fully. And so we started exploring different ways that we could link. We were already measuring our NBHAP, and we wanted to link our different areas to that. So we looked at sepsis that was coming from NBHAP. We looked at mortality that was coming from NBHAP. And then we started to paint the picture in whole for the different parties that we were trying to get involved into our project. And so we did start with the frontline staff. We actually did a toothbrush testing to show them kind of the bacteria that was present on our current oral care devices. We did forums with our staff to figure out what were some of the problems they were experiencing with our current process and completing oral care appropriately. We did baseline measures of our compliance with oral care and different prevention strategies to figure out, where are we currently? Why are we falling through? What's the numbers that we're currently seeing? And with that, we then kind of put together this whole package and presented it to our staff, to our managers, to our directors, and an admin team of here's the problem that we're having. And we explored solutions. And so we ended up on the Sage Stryker oral care device. And the reason we went with that was a few things. One, it helped with workflow. There was a lot of conversation about workflow. The bristles, as Barb mentioned, was a huge dissatisfier for staff and patients. If you brush your teeth and you have the bristles all over it, which is an increase for aspiration too. We actually ended up bringing our current toothbrushes and then the products that we were looking at, replacing it with to one of our board meetings. And all of our governing board brushed their teeth with all of the different products. They quickly saw the quality. So that was just a kind of a fun thing to do to get them bought in though on the project. And then we rolled it out. So we put together our bundle and what our process was going to look like. We put ways to measure the outcomes of that, measure compliance with that. We had the frontline staff bought in from day one. And so they were really pushing it forward. We did a lot of education on each floor and re-education, answered any questions as they came up, and we monitored it. So we wanted to make sure that the outcome was actually with the bundle use. And so we had goals set on compliance, which we were able to hit. And we did see a fantastic decrease in the areas that we were measuring, as I said, is NV-HAP and then NV-HAP associated sepsis and then also mortality related to NV-HAP. And our mortality actually came down by 50% in that year study. And so that was one of the things that we got to present at SHEA, which was fantastic. And more than anything, it was great for our patients, right? We're keeping our patients safer. And that's really the end goal.
Now, both of you helped implement successful programs. I'm going to ask each of you, what challenges did you encounter when establishing a non-ventilator hospital-acquired pneumonia prevention program? Elias, talk about your challenges.
Well, we needed to get buy-in, right? It is more expensive what we were proposing to do. So we needed the C-suite to really get connected with that and buy into that. And so that came back to painting that picture and connecting the dots into the areas of impact. And so that looked a little different depending on who we were speaking to at the time for our project. With our clinical leadership, like our chief medical officer and our CNO, we were really heavily focused on the patient outcomes. We were looking at, here is the data for sepsis internally. Here is our data for mortalities and the patients that are passing away once they've developed NV-HAP. And we really wanted to show them the true morbidity and mortality related to in our facility related to NV-HAP. And so a little different from when we went and talked to our finance and operation teams, we really stuck to length of stay. Obviously, that's a huge ticket item for them. We pulled information surrounding lost revenue that comes from that increase of length of stay. And then we talked through some of the logistics of how it was impacting workflow, how it was impacting throughput from an operational standpoint.
Barbara, talk about some of your challenges you encountered when implementing your program.
I think the lack of knowledge was really striking. Most nursing programs back in my day didn't even talk about oral care as a preventive measure. It was just sort of a nice to do. And so something's just nice to do, not understood to be as important as it is. Those are the things that fall to a lower priority for staff. So lack of knowledge was a big one. I think the perception by staff that, oh, you're just asking us to do one more thing. So again, that education helped overcome that. The data and the chart review, where you're trying to measure outcomes, it can be very labor intensive and laced with a little bit of subjectivity that has been difficult for some of us to overcome also. And then one surprising thing that ended up being a challenge was patients' refusal to do oral care, because they truly did not understand why, when they didn't feel good and didn't feel like doing anything, that we were asking them to brush their teeth. They just didn't feel like it was important. So those are a few of the ones besides what Elias talked about.
You're listening to a special sponsored episode of the podcast by Kevin MD, Patient Safety in Focus, helping to address risk factors associated with non-ventilator hospital-acquired pneumonia. Find out more at kevinmd.com/Stryker. That's Stryker with a Y. kevinmd.com/STRYKER. The link will be in the show notes. Again, I'm going to ask both of you the same next question. Barbara, what data or outcomes would you recommend tracking to measure the success of a non-ventilator hospital-acquired pneumonia prevention program?
Well, I think what Elias already spoke about, you need process and outcome metrics. You need to know that the nursing practice, the preventive strategies that you're putting in place are actually being done. And then, so those are things like the oral care frequency. Are you using the oral care supplies? Those types of things. And then the outcome, you want to know what the NV-HAP incidence is. And this is where we have some of the most struggles. I used the ICD-10 codes. I started with those. So that's the coded data, administrative data. And then I reviewed the charts and overlaid the NHSN definition to make sure that this was a valid data. This can be time consuming. I'm happy to say that there is a newer electronic option now that's available. It was published in JAMA by Dr. Barbara Jones and Dr. Michael Klompus, where they used electronic option where they identified the electronic pieces of the NHN definition and are able to run it in real time without the subjectivity. of how we were doing it before. So that's great. Hoping that that will make it easier for people and reduce the challenge of this part of measuring the outcome of NVHAP.
Elias, tell us about the data or outcomes that you would recommend tracking to measure the success of your NVHAP prevention program.
I think a good starting point for outcomes is as Barb mentioned, the ICD-10 codes. It's probably the simplest way, especially if you don't have a really big pool of resources and you're trying to kind of start gathering data. So that will give you your outcomes or your prevalence. And then as most important, well, again, Barb said, but the compliance. We need to figure out what is there a true association with what your practice is and what you're doing for the pneumonia. And so don't just look at charting is what I always say. I've moved away from just doing are they charting and documenting that it was completed? Do things real in-person review where you're saying, you know, even at we go up and we ask the patient, hey, how many times have you had your teeth brushed?
Mm-hmm.
You go and you physically look and see is there the oral care devices available in the room? How many of them have been used? Is it dated? So have a little bit more structure of the compliance and don't just rely too heavily on the charting of it, is what I would recommend.
And the next question, again, I'm going to ask both of you. Elias, we'll start with you. If you could change one thing about how hospitals address non-ventilator hospital-acquired pneumonia today, what would that one thing be?
I would just love to see it monitored more. I know that at my facilities it's one of the top things we look at and we've made it a priority, but I would just like to see more hospitals putting data out there for and it being available for them. I think that they'll see a lot more impact on their patient care in different areas, like we said, like sepsis and mortality and length of stay and things that they maybe aren't associating with that yet. That they would anticipate. And so that would be my big thing is just getting hospitals more bought in on really the impact they can have when you reduce NVHAP.
And Barbara, what would be one thing that you would change about how hospitals would address non-ventilator hospital-acquired pneumonia?
I think I would change their perception if I could do that. I had a magic wand, that they would perceive NVHAP as a preventable harm that's occurring on our watch, to take it as seriously as they do sepsis and CAUTI and CLABSI. There was a study that just came out from AHRQ recently that showed that HAP occurs 16 times more frequently than CAUTI. And yet, where is our leadership focusing? They're focusing on something that doesn't happen nearly as often and doesn't harm nearly as many patients. So I would say if I could change their perception that this is happening, it is happening to patients under their care, and that it is a preventable harm.
Elias, how can we increase the importance of NVHAP in the eyes of hospital leadership, staff, patients, and their loved ones?
Well, with leadership, right now, until we get ties to some of the different measures through either CMS or NHSN or one of those regulatory bodies, we really just have to show the correlations to what they're currently focusing on. And so that length of stay is a big one, the 15 days, and what that looks like from a financial standpoint. So it's estimated that an NVHAP probably costs facilities anywhere from $28,000 to $40,000 per patient. And if you start looking at that by occurrence, that can add up very, very quickly. And I think that's something that the leadership would be really big on. From a nursing standpoint, most of the prevention strategies for NVHAP are simple, right? If you're looking at all the things that can go wrong when a patient gets NVHAP that we talked about earlier, hey, the prevention for this is let's brush their teeth. And when you look at some of the other hospital-acquired conditions, it's not that easy, right? The mitigation strategies can be a lot and intensive. And so for this one, I always say it's one of the simplest hospital-acquired infections to prevent. Good oral care practice. And so that's what I really push towards them. And for the families and the patients and the loved ones, it's increasing the knowledge. So it's giving them that education. I still go up on the floors and I'll talk to a patient who doesn't want to brush his teeth, or just won't participate in that. And so it's just, explaining the importance of that oral care to them as well, and getting them bought in their recovery and their care. I think that will go a long way.
And Elias, speaking of knowledge, where should viewers start if they want to grasp the scope of NVHAP at their hospital?
Easiest thing's going to be, if you don't have a measuring mechanism already, is the ICD-10 codes to start with. Start looking at that. Contact your data team, your CDI team, or maybe your HIMSS team. See if there's any sort of queries you can run. Depending on what EHR system you have, it might be easier than others, but just try and look at the outcomes first. And then if needed, I think you try and correlate those patients to some of the other things you're looking at. Look and see, did those patients have a higher frequency of readmissions? What was their average length of stay? Did they end up developing anything else like a hospital-acquired sepsis? And so see if you can start, but you start with the ICD-10 codes, figure out that patient population, you can dig deeper.
All right. And now we're going to end with some take-home messages. I'm going to ask both of you to leave with the Kevin MD audience. Barbara, why don't you go first?
I would say my takeaway message is to make the effort. Look at your own data. Don't assume this only affects other hospitals and not yours. Really takes courage to look for hidden harm with all the other requirements that we have in healthcare right now. But our patients are counting on us to do the right thing.
And Elias, what are some of your take-home messages?
Just that we're all advocates for our patients. And if you see a problem, even if it isn't something that's at the top of the list, escalate it, and don't be afraid to voice your opinions on it and work on it. That's our job as clinicians. That's our job in quality, is to raise awareness. And so just continue to do that.
Thank you for listening to a special sponsored episode of the podcast by Kevin MD, Patient Safety in Focus, helping to address risk factors associated with non-ventilator hospital-acquired pneumonia. Find out more at kevinmd.com/Stryker. That's Stryker with a Y, kevinmd.com/STRYKER. The link will be in the show notes. Barbara and Elias, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.